So let's not skip the presentations and jump to closing remarks. Let's see how we are now. At the beginning, we have the question. You formulated it according to the PICO strategy. So you know how to formulate questions, scientific questions, by the PICO strategy. After that, you developed the search key and applied it to many scientific databases. You downloaded the database content to build up a single pool of the records. Then you selected them, collected all the relevant data from these articles, and put it to the statisticians to do a perfect analysis. You have some numbers. And most review authors think that the process has ended here. However, you should always ask this question. Do you believe that your results reflect the truth? And to answer this, here you have my presentation about the risk of bias assessment and the grade approach. What is bias? We frequently use it. I think you heard it today at least 10 times from all of the lecturers. Bias means a deviation from the truth, a systematic error affecting all the results and distorting the results. Bias may lead to over or underestimation of the effect estimate. Of course, it can be neutral as well. However, both false positive and false negative conclusions can be drawn due to biased analysis. Sometimes there is a misunderstanding because some authors mistake bias for imprecision. As you may see here, this is the truth average, and this is the false one, and the bias, the confounding factors, shift the average to the direction of the false one. In the case of imprecision, the studies, the average of the studies, just scatter on a scale around the truth average. There isn't any shift in it. The imprecision is typically the consequence of the low number of participants, low sample sizes. Another common mistake is the risk of bias assessment and the methodological quality. Actually, the confusion of these. Because you may have studies having high methodological quality, however of high risk of bias. Why? Because authors do not design their studies to fit our meta-analysis. They design their studies to fit their purposes. And sometimes we just extract the data, the negligible data, the data negligible for them, according to the primary purposes, from the supplementary sections. And when I assess the risk of bias in my point of view, in my perspective, according to my goals, it results in high risk of bias. The classification of biases can be manifold. In the followings, I'm going to describe the most common types of bias. The first, what I should mention, is the so-called selection bias, and this name speaks for itself because selection bias means the biased selection of patients into one study. What does it mean? More specifically, there is a difference between the baseline characteristics of the study arms. One arm is older than the other. One arm has a more advanced disease than the other. So there are differences in the hidden prognostic factors which may bias the reaction to the intervention. At the very end, this will result in such an effect which just distort, shift, or mask the measured effect of the intervention to the false average. Because if I see a difference, I cannot differentiate whether it's the consequence of a baseline difference. For example, the higher mortality of one arm is the result of the higher age of that arm from my intervention. I cannot measure the effect of the pure intervention due to several confounding factors in the baseline. How can I prevent it? By appropriate randomization. All studies which are not randomized suffer from selection bias. all of them. Randomization can do a random allocation of patients to study arm, which equalizes, neutralizes perfectly selection bias if the randomization is effective. That's why randomized controlled studies are of the highest level of evidence, if they are adequately designed, of course. We have tools to assess risk of bias. They cannot be measured mostly statistically. We are talking about the risk of bias within the individual studies, not the systemic bias forms such as the publication bias, as Alexander mentioned. There may be problems with the random sequence generation and the allocation concealment. If the sequence is not real random, then the randomization will not allocate the patients randomly by chance. For example, if there are so-called quasi-randomized studies, when the day of the week decides which group, to which group a patient will be allocated. These are not real random sequences. Random sequences can be generated, for example, by computers, by random number tables. Allocation concealment. Sometimes the investigators want to know to which group a patient will allocate it. And this makes a chance for prediction, which may bias the allocation. If I know which intervention a patient will receive before I incorporate him into the study, it will bias me when I decide whether the patient is eligible for inclusion or not. Let me tell you an easy example. There is a new type of treatment. The old type of treatment is not really effective, but that's the standard one. I know the patient, he is my relative, or he is one of my good friends, or he suffers from an advanced disease, and I just want him to get the new treatment instead of the old one. If I know the next name in the envelope, if I know which treatment the patient will receive after randomization, then I can decide whether I enroll the patient or not accordingly. That's the source of bias. The second one is the so-called performance bias. Again, performance. Something influences the performance of the doctors, the performance of those who do the intervention. For example, if the surgeon believes that the old procedure is better than the new one, probably the results will be different as compared to that situation when the surgeon has no prejudice. How can you prevent it from happening? By blinding. If those guys who do the intervention do not know which group the patient belongs to, there is no chance for performance bias. The other one is the detection bias. You know that the endpoint of the studies can be complications. Let's assume pneumonia. How can you detect pneumonia? By ordering an X-ray. What if I say that I believe that the old treatment is better than the new one, and I order an X-ray more frequently to those who receive the old treatment, to the new treatment, because I don't believe this is ethically correct, for example. Then, because I order more X-rays, there is a likelihood to detect more frequently pneumonia on that arm. That's the so-called detection bias. I am biased when I order the detection tools, when I order those interventions required to define an outcome. How can I prevent it from happening? Again, blinding of investigators, blinding of outcome assessors can prevent it from happening. The next one is the dropout, the attrition. You know that typically not all patients finish the whole study protocol. When the dropout occurs, it may neutralize the randomization. Why? Because the dropout is not always random. If the dropout is not always random, for example, the dropout rate of the new drug is higher than the old one, it may be the consequence of the harmful effects of the new drug. Okay, and this non-random dropout will eliminate the randomization, causing an imbalance in the baseline prognostic factors again. How can I minimize it? Of course, I cannot prevent it from happening because dropout, well, is a need mostly. However, there is the so-called intention to treat analysis, when I include all the participants in my analysis who were randomized, and there is the so-called per protocol analysis, when I include only those who fulfill the entire protocol. The latter one necessarily has the lower number of patients included in it. If you just try to estimate the data of those who dropped out, for example with statistical imputation, there is a chance that the effect of randomization will not be neutralized. Another approach is the check of incomplete outcome data. If you observe a difference between the numbers of those included in the study and included in the analysis, that means a dropout. And that raises concerns of attrition bias, of course, and this should be investigated because it may bias your results as well. And the very last one is the reporting bias. We were talking about protocols. Let's assume you wrote a protocol for randomized controlled study, you published it, but you can explain only 8 of 10 outcomes. And there is another one which you just disagree with. And you just miss writing it in your publication by accident, I'm not really sure. But if you cannot explain something, I think you're prone to hide it. That's the so-called reporting bias. If you take a look at the example, studies are more likely to report about harms than that of efficacy, for example. How can you prevent it from happening? By checking the complete reporting. If you check the protocols of a randomized controlled trial and compare it to the publication, to the manuscript of the publication, you may observe these differences. If you detect it, reporting bias may occur, of course, and this raises concerns about the validity of the study as well. Remember, if the studies you include in your meta-analysis are biased, it may bias the pooled estimate as well, your conclusion too. Because if you just pull garbage, it will result in garbage. However, if you use the top publications, it will result in a top conclusion as well. So the aim of risk of bias assessment is to assess the internal validity, the risk of bias, the quality of the individual studies, to discover, to explore all potential sources of bias. To do it, you have tools. The Cochrane tool for randomized studies and the Newcastle-Octavian tool or SCAL for non-randomized studies. You should adjust this tool, but not the Cochrane risk of bias tool, because, well, that's a really good one. The Newcastle-Octavian scale should be tailored to your question, because that's a really a-specific one, and that's for observational studies. And as I mentioned, observational studies often suffer from bias. It is mandatory that, for example, selection bias is present in these studies. So some authors just question the need for risk of bias assessment in observational studies because bias is inherent in this genre. And the conclusions drawn from observational studies is typically weak as compared to the randomized studies. Risk of bias should also be assessed by 2 review authors in duplicates, and discrepancies should be resolved as well. Do not use risk of bias scores because they are arbitrary. They shouldn't be included in the statistical analysis because we have no rationale for doing it. You should display it in a tabularized or in a graphical form. Here is a tabularized form of risk of bias. The green ticks represent low risk of bias, the red X represents the high risk of bias, and we have some questions on certain risk of bias here. This one is a typical risk of bias graph, and this one is another common graphical setting of risk of bias presentations. Study by study. Let's take a look at the rows. Risk of bias assessment should be incorporated in both the methods, results, and discussion sections, and mostly in the limitation sections of the manuscript in the discussion. Let's see an example. Here is a statement. Statins reduce cardiovascular mortality in patients with hypercholesterolemia. Here we have a question. How confident are you that this is the truth, that this statement is true? According to the guideline, we are quite confident in it. We assume that if you reproduce the studies, they won't yield different results from it, because the quality of the studies is high and we have several randomized controlled trials showing this conclusion. Each statement you provide based on the results of your statistical analysis should be graded by evidence, because you can state anything, but if you are not confident enough in that, that means almost nothing. How can you do it? By applying the grade approach. The grade approach has a scale by confidence. If you are not confident in your results and further studies may result any other conclusions, the grade of evidence is very low. If the further studies are unlikely to change the grade of evidence, they are unlikely to yield the different results, then you are quite confident in your conclusion. In this case, the grade of evidence should be high. So please pair your statements with the grade of evidence to ease readers to understand it and to decide whether they should organize a study in this question or they should apply it directly in the clinical practice. How can you apply the grade approach? The first step is to decide what kind of study designs do you have included in your analysis. If you have only randomized control studies included, the baseline grade of evidence is high. If non-randomized studies are included, at least one in your analysis, then the grade of evidence is considered to be low at the beginning. This should be done for each outcome, for each statement you make. If you take a look at this chart again, you may recall your memories about randomized controlled trials. This, I mentioned in my previous lecture that this genre is the recommended one to be included in meta-analysis. This is the first preference. Cochrane reviews only use randomized controlled trials because they provide a pure evidence without confounding factors, theoretically, of course. All the other ones, all the observational studies are of low grade of evidence. Let's take an example. Here is an analysis. At the top, you can see the observational studies. The conclusion is of low grade of evidence. If you take a look, but you don't see, we see a significant difference between groups here. The risk ratio doesn't fall, so the confidence interval doesn't cross 1. So this represents a significant difference based on the observational studies. However, with low grade of evidence. If you take a look at the results of randomized controlled trials, we see only a neutral association for the same question, for the same outcome. However, this is of high grade of evidence due to the randomized natures of the study. If you pool both observational and randomized controlled trials, again you see a significant difference between groups. However, due to the observational studies included, the grade of evidence will be low again. Which one is the truth? That's the typical question. Of course, this one of high grade of evidence, because here you only have randomized control studies. Of course, this suggests a neutral association. Here, the significant difference may be attributed to confounding factors, to baseline differences, for example, between groups. The second step of the grade approach is upgrading and downgrading the level of evidence along these points. You should include risk of bias, heterogeneity, the applicability of the questions, how the study fit your PICO, the imprecision covering the sample and event numbers, and the publication bias as well. If any of these is flawed, then the grade of evidence should be downgraded even if you included randomized controlled trials, it's possible to reach very low grade of evidence. And that's the typical one. In Cochrane reviews, you barely see no high grade of evidence because they are very rigorous in the case of grade of evidence. If you are uncertain, grade it down, just for the sake of safety. You may have some upgrading items, they are rarely used. So let's see again our examples. Statins reduce CV mortality in patients with hypercholesterolemia. This is of high grade of evidence. What if I modify the PCO? Statins reduce cardiovascular mortality in patients above 80 years of age with hypercholesterolemia. Are you sure that the same grade of evidence applies to this subgroup of patients? What about the rationale for primary prevention, cardiovascular prevention above 80? I'm not really sure. And I'd like to point out to that subgroups should be graded separately if you draw separate conclusions. Okay. These are some useful links about how to grade. And the take-home message: are you sure about that your findings are the truth and the real truth? Thank you.